Hello and welcome to Bristol Health Cares. I'm your host, Kurt Barwis. I am the president and CEO of Bristol Health. This program is for you. It's really about how you navigate the system of care, how you access care, and it's really about trying to answer questions you may have and really didn't know who to ask. We are going to bring to you professionals, doctors, surgeons, other healthcare professionals throughout our system of care, maybe people that you've never talked to before or met before, but the goal is to really help you understand how to access care when you need it. You're going to enjoy this program. This program is really for you. So what's important is if there is something that you want to learn about or know about or a guest that you'd like me to host on this show, write us and we'll try to make that happen for you. So enjoy the program, Bristol Health Cares. Hello and welcome to this episode of Bristol Health Cares. I am your host, Kurt Barwis, and with me today I have Ellen Andrews. I've worked closely on the governor's healthcare cabinet for years. Ellen is the chairman of the board of the Connecticut Health Policy.
And executive director.
And executive. I thought I was looking earlier and I was a little confused by that. So how about tell us a little bit about yourself, Ellen?
About myself. Well, I'm an advocate, state-based advocate, consumer advocate. We do a little, as much lobbying as the IRS allows for a nonprofit. And I'm mostly a policy analyst. There are a lot of advocates who are organizers. I don't do that. I work closely with them, but I spend a lot of time in Excel spreadsheets.
Yes, I know that. I'm very familiar with that. You know, for the audience, advocacy, being an advocate, what does that mean to the average person? How would you define that?
What that should mean is, and there's no licensure for advocates. There's no club you join. There's no certification. There are a few programs, but I don't know any advocates who've been to it. Basically, you work to improve access to health care for people. Now, our mission is for everybody in the state, huge, and to improve access to affordable quality health care. But there are advocates who work on behalf of people who have particular conditions, maybe cancer, sickle cell, disease conditions, people who care about populations, people with disabilities, communities of color. And so there are different kinds of advocates, but that's what an advocate is. And we do it by organizing, we do it by policy making, we do it by shaming, we do it by, press. Some work on campaigns. A lot of people don't know that advocates and nonprofits can, as long as you're even on both sides. But yeah, we used to sponsor debates, candidate debates, and ask just healthcare questions.
So one of the things, the way I kind of look at it sometimes is to think to myself, what if there weren't advocates? What would the healthcare system look like?
It's a really good question. I think that's a different question. I used to work for the Council of State Governments as well as the Health Policy Project. And we also went up into Canada. And when I went to the Canadian provinces and, the capitals to try and find someone like myself, they just don't exist. The people who do what I do are inside government. So I think here in the United States and certainly here in Connecticut, there are inside advocates. There are people who care a great deal and spend all their lives in Excel spreadsheets. But, everybody works for an industry, or they work for a politician, or they work for, eventually for the governor, for the administration. And I don't work for any of those people. I can say whatever I want. So it's an outside voice. I'm not tethered by anything but my own conscience.
Yeah, but you do it extremely well because you do care a lot about people access and getting the best quality health care. I mean, that's been my experience. So when I think about how the machine works and everything is synthesized, it's a daunting task. I mean, just last session, we had so many healthcare bills in the state. It's almost like you wonder, okay, are we finished yet? It's never done.
Right.
So how do you think this process works in terms of health policy?
It's a great question. The process kind of doesn't work. And part of my job is getting it to work better for people. But you made a really good point about the opportunities, and there are 1,000 opportunities for advocacy, and you kind of have to decide. And that's why a lot of advocates have chosen one population or one condition or maybe one geography to work on. The way we do it is where there isn't already an army of advocates working on things like Medicaid or reproductive rights, things like that are things I support, but they don't need me. I work more in places where, like consolidation, where we've talked an awful lot about that.
Right.
That Bristol is an independent hospital.
You're going to call me out on this show. That's okay.
It's a wonderful thing. No, it's a really good. That's why I'm here, actually, to support you.
I appreciate that, and you know how I feel. So.
Yes, and consolidation into big, huge systems. And it's not that I don't understand the pressures that independent hospitals are under and how attractive it would be to join one of those big ones. But that's how we keep prices down. That's how you stay connected to community. And so that's something I work a lot on. And so I've chosen that as an area, as an advocate. And I also think about it in terms of sort of at the 40,000 foot level rather than each CON, certificate of need application for each particular service. There's a lot of calls for advocates to come out for something like that. And it's like, so we stop that one, but how do we sort of deal with the bigger picture?
Yeah, somebody asked me a couple weeks ago, so what is the strategy for the state of Connecticut? How does this all, is there a strategy? And I mean, in my almost 18 years here, I think I've heard that question probably a lot more times than I care to kind of think through.
Yeah.
But it sometimes doesn't feel like there is an organized strategy, that, you have different feelings, and you've got the administration, and you've got the legislature, and within the legislature is different, and then you've got the staff and everybody else. I mean,
right.
Is that a valid concern?
Yes. Very valid concern.
And how do we fix that problem?
I was talking with my husband this morning, actually, about the culture of a place. And I think you can have a vision, but there's a lot of places that have visions and they don't really follow them. They say it, but they don't mean it. So it's about the culture of a place. And I think about the culture of Connecticut and how it, it's different than other states, very different. And very, one commissioner who came here from somewhere else said, it's really interesting. Connecticut's very transactional. Yeah, that's a nice way of putting it.
No, that's probably a good point, actually.
And so I think there are things where that's actually where it's really helpful to be an outside advocate, not working inside, because it's a question of whether, you can do more good inside, and plenty of people do. But I'm an outside advocate where I can call people on it and say, and I can call them on it in the press and say, you claim this is your mission, but you're doing this.
Yeah.
It's actually, it's scary to do that, frankly.
Yeah.
But it's incredibly heady that I am in a place where I can do that.
No, and I think it's such a valuable thing to have everybody's view being heard and voiced.
Yes.
Because hopefully at the end, we get to the right decisions. I just kind of going back to this last session and some of the things that, kind of really concern me, and I concern others about Connecticut, because we talked a little bit about that. But, there's a lot of agencies and community organizations that do tremendous work in terms of access to healthcare. I mean, I just was at the annual dinner for CMHA in New Britain, although they had it in Bristol where they started. And they talked about the funding deficiency. And I heard it all throughout this last legislative session that some of these agencies haven't seen an increase since 2016.
Yes.
And, for me as a person, and having traveled a lot around this country and seeing some other cities where all you heard about was economic development, this, we got, new business, new roads, blah, blah, blah. And yet they didn't focus on the social welfare of their communities.
Yeah.
Those communities are in serious trouble. I mean, you see the businesses leaving. I was in Seattle a couple of weeks ago. A horrible experience. I mean, just homeless people everywhere, people doing drugs open on the street. And so I feel like we may have lost some of that balance in this state, that those agencies need the support. And I think there's a disconnect between how do you sustain economic development and that it's really truly inseparably linked to the health of the population.
Right.
All of the population, everybody.
Right.
So
yeah, I would love to someday do a count in the Connecticut's press to see how often taxes come up and how often healthcare comes up or social services, because I think it would be, just incredibly unbalanced. I think there's a feeling that if we do a better job with economic development, then tax revenue will come in and we'll spend it. But that's not, they don't always connect those dots.
Yeah.
And it's real, that's another cultural issue in Connecticut. Maybe it's America in general, but in other countries, they do a much better job of understanding, looking upstream and understanding that if you get people housing and food, they're a lot less likely to end up in the emergency room or in the hospital, or worse. Yeah.
Well, you know better than I do because you're also a professor at Yale and you teach this stuff. But I think what I've heard and I truly believe is that the developed countries, the ODAC countries, spend a lot more on social welfare programs, and as a consequence, they spend a lot less on healthcare. And when you add it up, we're in the middle of spending, but we spend it all on healthcare and not on social welfare. So your comment about it's not just Connecticut, it's a national issue. It truly is, but it seems like it's hard to convince people that this will ultimately bring this down in terms of cost.
I don't think that's a hard case to make. People themselves know that if they eat better, if they exercise, if they stop smoking, if they don't drink too much, that they're going to be healthier. And people are, most of us are doing our best, frankly, with that. So I don't think that the idea of giving supports to people that you don't necessarily know will help them be healthier. That's not a hard leap to make. I never have trouble with that. The trouble is paying for it, that it's always easier to just Band-Aid things. Band-Aids are cheap. They're really cheap. Workarounds are easy and fast. Doing things right takes time and energy. And in some things, we're willing to put that time and energy in. In healthcare, we generally don't. All the energy and thought and frankly, the power is in the sick care industry, unfortunately. But I think you're right about the upstream issue and that it is a cause of our high health spending in America. But another reason is prices. Our prices are just out of control. They're much higher for things that, like an MRI machine, things you switch on. It doesn't matter, that education costs more here than it does in Scandinavia. An MRI machine costs the same to make wherever you are. And so it shouldn't cost 3 times, 5 times as much. And so prices are a problem. And a lot of that is around the consolidation of insurers, of health systems, just across markets and within markets. And I think we've all seen that. And it also reduces consumer choice. I live down near New Haven. And when I had my son 35 years ago, I had 2 hospitals to choose from. Now my daughter-in-law will only have 1. She will go to 1.
So the economics of the acute care side I know very well, and it's not an easy.
Right.
It's not easy, and it's unfortunately, very hard in Connecticut, and there's a lot of it's more than multifactorial. It's really a complex thing, and it's not just what happens within the organization or the consolidation. It also has to do with the malpractice environment in this state. I mean, you have awards that are $30+ million. I came from Maryland where they had non-economic caps. And, what I hear always is the argument is, well, it's not going to reduce the fee tomorrow. Well, in Maryland, it took a couple years, but guess what? Malpractice insurance became affordable, right? And nobody really intends to do harm. So, and that's just one aspect of it. But I think, part of the dilemma is that in that consolidation effort, that has happened in the state, which we've had a lot of it, obviously. I won't shy away from that. that it's we have policies that are kind of one size fits all, and it's always a percentage of cost. And so you have, and I'm a big believer in looking out for that. Let's try to help that homeless person. Let's try to help the disadvantaged person. In Connecticut, that's not how hospitals are treated. It's one size fits all. This is we're going to pay you a percentage of cost. But if you go to other states, we have 73% government pay mix, 73%. So it's almost impossible for us to get beyond break even by but just a hair. But so that's a factor that's considered in other states, yet it's not in our state. So and it's simply, we have the 4th lowest reimbursement for Medicaid in the entire country. And in other states, like just next door, they look at that and say, you have a very high government pay mix. We're going to help you by giving you more than 100% of cost for Medicaid. So you won't go out of business and we won't lose access.
Right.
And just this last year, you saw extreme increase in costs and prices. I mean, even the report that came out of the state said that. Yet, if you look at the Medicaid reimbursement, it dropped down through 2022 from 64 to 62% of cost. And Medicare went from 82 cents on a dollar cost to 74. So I don't see it getting any easier in this state. And in fact, we tend to look in the past, but I'm not hearing anybody say, okay, so we've got 2% increases for the next 3 years. That's going to put even those big systems in trouble.
Right. Tell
anyway.
me how you really feel about this.
I'm sorry, but you.
No, you're
right.
right.
So
you're
I just I just feel like we don't do enough future consideration of, and that's my own.
And it's a fairness issue. Somebody always said somebody should be paid just as much to take care of my son as they are to take care of a child on Medicaid. That shouldn't matter, maybe more. And you've got a point. And the state is looking at Medicaid reimbursements and increasing payments. The problem is we looked at this the last time, well, it may not have been the last time, but it was a while ago, and it doesn't happen often when Medicaid rates are increased. And they were significant. It was more specialists too, because we needed specialty care access. And we found no increase at all. And we did not find more providers taking more patients. We saw the same providers seeing the same people for the same amount of money. Now, on a fairness issue, that's okay, because they should be paid closer to what they get. And nationally as well, with the Affordable Care Act, when they brought primary care rates up to Medicare, and Connecticut, I'm proud to say, kept it there when other states, the feds let it go.
Primary care.
Right.
No question.
But in fact, it didn't make a difference nationally in terms of the number of primary care providers or the number of patients they would see. So as an advocate, if we're not, we need to get value for the money. So when we see those increases, I don't disagree that we need those increases, but if we spend it on that, we're not spending it on housing, we're not spending it on food, we're not spending it on all those things. There are big opportunity costs to all of that. And as there are more and more big systems, which Bristol is not part of. How many times have I said that? Which is a great thing. But in those big systems, we're concerned, for instance, that people with developmental disabilities have a huge problem getting into primary care. And there was just research out, this was national, about physicians have real resistance to it for reasonable reasons. It can be, you get 15 minutes with a patient. It can take 15 minutes to get somebody out of a wheelchair. You're just, you're not paid for that time. Also, there are concerns about, legal concerns and other things. So we want to move around all those things and address the problems. But how do we know if we give the money to a large system that will actually translate to that physician getting 30 minutes with a patient? We need to make sure that it connects to improving people's care.
Yeah, you mentioned the social determinants, like housing, food insecurities, and all those things. And those things are, I think, on the mind of every person that runs the systems, because I look at it and say my economics, my future is really inseparably tied to the economics of the community and the health status of the community. So if I don't reach out beyond my 4 walls and participate and work through those kind of things, it will really cause a systematic failure. It's an ecosystem, and so I believe we will turn around and do those things, because we know that that's what it's going to take.
We don't
to
have
survive.
any choice. We have to.
Yeah. but I also kind of am very sensitive to when I hear, support structures that I need. So in order for me to, I'll give you an example. I have a patient that's been in the hospital for more than 200 days. I haven't gotten paid a thing. $1 million in cost.
What's the payer?
It's Medicare Advantage. $1.1 million.
Wow.
And why? Because we don't have a full available network of post-acute ventilator dependent, care in our state. And that person's been in the ICU. So, how do I overcome that?
Justify that.
And I just spent, time in Washington, at the AHA meeting, and actually that's a national problem.
Yeah.
And why is it a problem? Because it's cheaper to leave that patient in my ICU because they're paying me nothing because I'm getting paid on a geometric length of stay and crumbs versus what they would have to pay to a specialized post-acute facility, which I know is a pretty complex conversation, but let's fix that problem. And I have more dollars to go out and deal with my opioid task force program, dealing with obesity in the schools. We tried to tackle that problem and expanding my ambulatory behavioral health network, partnering with FQHCs, partnering with Wheeler Clinic and CHMA, which is struggling because of the loss of increases. My discharge plan is often connecting them with those programs for the homeless.
Yep.
If I don't have a safe discharge.
But discharging somebody to a waiting list doesn't do them any good.
That's exactly. You've totally. So it just seems I'm going to go full circle back to a comprehensive plan, which does, kind of balance and take into consideration all those things is really where
one of the problems that you're talking about is that we have chronically underfunded public health. It's been a huge issue.
Yeah.
And that is also not just Connecticut. And then COVID happens and all of a sudden money comes in. Well, you can't turn that money in, while everybody's on lockdown to immediately, everybody has masks and PPE. So we need to have, it's great that you're doing all that stuff, but you're a health system. You're not, a public health system. You're not a housing. You don't provide housing to people. You don't provide, food. We need partners for you that are well resourced in the community. And there are things, public health isn't, give away food and give away housing.
Right.
There is good evidence around what works, what doesn't work. I used to teach public health at Southern, and we know what works. We know what doesn't. It's been tested. We know how to spend the money. And that is like the best return on investment that we could ever do, but we don't. We just don't. Not until there's a pandemic. Funding goes up and then it goes down again and we forget about it.
And then funding actually goes down lower than it was before to make up for what we got. So Ellen, any last, thoughts for the viewing audience?
I'm just so grateful. It's grateful to be able to have these kinds of conversations all the time. And I can call you and you'll come and talk to my students or tell me what I'm getting wrong about hospital accounting. But it is also great. I was thinking on the way up that you're the first person I remember hearing from about violence against clinical staff in hospitals, that you are a bellwether to bring up things that people are just not paying attention to, and you're in the real world. Which
thank you. So it's a serious problem. I think it's 5 times a day in Connecticut we have an act of violence towards a healthcare worker,
and a lot of them are my students. I hear about it all the time. Yeah,
it's sad, and the thing that really bothers me the most on the national level is it's a crime, a federal crime, to hit an airline stewardess or verbally abuse or attack one. Yet you can hit a healthcare worker and nurse, anybody, respiratory, you name it, the person who registers a patient, and it's not a federal crime. And we have a lot of work to do there, I think, as a country. So
we do.
So I just really appreciate what you do. I value and appreciate it. And I feel like we all make better decisions when we have opposing ideas and thoughts. That maybe they're not necessarily opposing, but you
Sometimes
get
they
the
are,
best
and that's
stuff on the
okay.
table, and then you try to kind of move forward. And that's what I love about you is you're not afraid, and you're usually very well steeped in the data and the facts, which I love too. So so thank you for coming on and doing this with me.
Thank
I
you for
appreciate
having
it.
me.
Yeah. So this has been another exciting episode of Bristol Health Cares. Thank you so much for viewing our program. I love to hear your ideas and thoughts about who I should have on the program, we should have on the program in the future. You can write me at cares@bristolhospital.org with your ideas, your thoughts, and questions. I would be remiss if I didn't mention this amazing organization that produces this show, Nutmeg TV. Please support them. Please support them because they do just an incredible job of bringing nonprofit, public engagement to programs that you can see on cable TV and then ultimately on YouTube as well. So thank you again for joining us today in this episode, and I wish you all a wonderful rest of your day.